This is a presentation on hip osteoarthritis by Philip Kennedy and Meredith Ehrenheim. Hip osteoarthritis involves a focal loss of articular cartilage with variable reaction of subchondral bone. As the disease progresses, osteophytes or spurs may develop from excessive force. Sclerosis of subchondral bone and cysts may occur due to the increased focal pressure on the joint. There are two types of hip osteoarthritis, primary and secondary. In primary hip osteoarthritis, there is no predisposing factors, and is a result of aging alone. Secondary hip osteoarthritis follows previous damage by disease or mechanical disorders or trauma, such as a posterior hip dislocation.
Prevalence of osteoarthritis of the hip. Arthritis is the leading cause of disability for adults in the United States. The most common type of arthritis is osteoarthritis. The prevalence of osteoarthritis of the hip has been shown to be anywhere between 0.4 and 27%. This figure is the range of prevalence estimates according to a systematic review of 23 studies with a mean prevalence of 8%. This wide range is due in part to the various populations studied as well as each study's parameters in defining the condition. Another estimate determined in the Framingham osteoarthritis study, which looked at people aged 45 and older, showed a lifetime prevalence of 6.7%. Diagnosing hip osteoarthritis. The gold standard for diagnosing hip osteoarthritis is a plain film radiograph. Hallmark signs of the disease include a narrowed joint space indicating cartilage damage and signs of reactive changes in the joint, including osteophytes, cysts, and subchondral sclerosis. A clinical prediction rule exists for classification of hip osteoarthritis in the clinic. A clinical classification of hip osteoarthritis is appropriate for patients who present with pain in the hip, as well as one of the following two clusters of symptoms: greater than 50 years of age, hip internal rotation of less than 15 degrees, and hip flexion less than or equal to 115 degrees, or greater than 50 years of age, morning stiffness that lasts less than 1 hour, and hip internal rotation greater than or equal to 15 degrees that causes pain. This criteria was developed through a study by the American College of Rheumatology, which studied 114 patients with hip osteoarthritis, as well as 87 control subjects. When compared with radiographic evidence, this criteria was shown to have a specificity of 75% and a sensitivity of 86%. Risk factors. The most strongly associated risk factor is age. Hip osteoarthritis commonly affects middle-aged and elderly populations with a rise in incidence during the 50s and 60s. Previous injury, which often results in abnormal articular surfaces and altered load bearing in the joint, is also strongly correlated with unilateral hip osteoarthritis. Developmental disorders within the hip also show a high correlation to developing hip osteoarthritis. These disorders can include leg calf perthes, slipped capital femoral epiphysis, and hip dysplasia, including femoral anaversion or retroversion, and coxa vara or valga. Genetics also has implications in the development of osteoarthritis in the hip. There is a high prevalence of hip osteoarthritis in Caucasian populations, whereas studies of Asian, African, and East Indian populations showed a very low prevalence. It has also been shown that siblings show a high correlation in developing hip osteoarthritis, pointing to a familial component. Some studies have suggested that obesity also correlates with development of osteoarthritis, although further studies will need to be done to adequately show this. However, there is strong evidence that patients with osteoarthritis who have a higher BMI will progress in the disease more quickly than those who have a BMI in the normal range. Finally, high-intensity sports involving direct impact to the joints, especially those with repetitive joint loading and twisting motions, have a strong correlation with early onset hip osteoarthritis.
Patients may present with signs and symptoms including discomfort and bouts of pain related to activity, stiffness following inactivity, difficulty climbing stairs or putting on socks, and as the disease worsens, they may experience severe pain at night or while resting. Upon your physical examination, you may observe restriction of internal rotation, abduction, or flexion of the hip. Initially, the pain will be felt in the groin or trochanteric area and progress to the anterior thigh and later to the lateral and posterior hip or thigh. The patient may also present with weak hip abductors. While not validated, the clinical prediction rule for hip osteoarthritis has a positive likelihood ratio of 24.3 when 4 of the 5 following factors are present: a self-reporting squatting as an aggravating factor, active hip flexion produces lateral hip pain, a scour test with abduction causes lateral hip or groin pain, active hip extension causes pain, and internal rotation passive range of motion is less than or equal to 25 degrees. During the acute phase of hip osteoarthritis, your goals are to decrease pain and inflammation through grade 1 and 2 mobilizations, especially distraction and inferior glides. The patient may need a cane to decrease the level of stress to the hip joint. If there is a leg length discrepancy, a heel lift can be utilized. During the subacute phase, goals are to increase range of motion, strength, and endurance. Stretching exercises should target the iliopsoas, the rectus femoris, the adductors, and the hamstrings. Mobilizations can be used to increase capsular extensibility, especially the medial, inferior, and posterior capsule. An emphasis should also be placed on strengthening the abductors and the extensors. Patients may also benefit from aquatic therapy. The prognosis of hip OA depends primarily on the extent of radiographic evidence. The prognosis is commonly assessed with the Kellgren-Lawrence scale of joint space narrowing. Outcome measures for hip OA include the Western Ontario and McMaster University's Osteoarthritis Index, or the WOMAC, which has an MCID of 12 to 20%, the Lower Extremity Functional Scale, which has an MCID of 9 points, and the Harris Hip Score, which has an MCID of 4 points. The Harris Hip Score was originally designed for secondary hip OA. The WOMAC and the Harris Hip Score have a ceiling effect as they are primarily designed to assess patients prior to surgery. That concludes this presentation.